It's my pleasure to introduce Dr. Rogawski McQuade, who's an assistant professor here at Emory in the Epi department. Dr. McQuade completed her undergrad here at Emory, majoring in biology and chemistry, and then went on to complete her MSc and then PhD in epidemiology at UNC Chapel Hill in 2015. She then did a postdoc at the University of Virginia, where she stayed on as assistant professor until 2021, when she could not join faculty here at Emory. Her research in pediatric enteric disease in low resource settings crosses many scales by considering the complex interactions between early childhood diarrhea, enteric infections, environmental enteropathy, antibiotic use, and the effects on child health and development. She's also interested in better understanding the impact of vaccines and other interventions for enteric diseases. Here at Emory, she's also involved with EVE, the Emory Alliance for Vaccine Epidemiology. She co-teaches infectious disease epidemiology concepts and methods. She's a co-investigator and PI on multiple grants, mostly focusing on enteric disease in early childhood. She mentors many students, but most importantly, she's my dissertation teacher. So thank you, Dr. McQuade, and warm welcome, and we look forward to your talk.
Thank you so much, Mary. That's great. Just short. So yeah, really happy to be here, and we'll be talking to you about an aspect of my work that hopefully is of interest to this group, specifically focused on antibiotic use for kids with diarrhea. And the provocative title is Too Much and Not Enough, which hopefully you'll understand by the end. So just to give you a little roadmap, so first talk about the burden of antibiotic use in this population, describe some of the work I've done to characterize negative consequences of that use. On the flip side, highlight some opportunities for benefit, and then end with potential interventions and some of my more recent work. So starting with the burden of use, I'll introduce one of the primary studies that I worked on over the last, almost a decade now, which is the McQuade study. So this was an observational birth cohort study. Sorry. So this was an observational birth cohort study of a multi-million-dollar project funded by the Bill and Melinda Gates Foundation, conducted in 8 sites in South Asia, Africa, and South America. And it had just an incredible richness of information collected. So children were visited in their homes twice per week. And so we have information on illnesses, medicines, food intake, essentially every day of their life from birth to 2 years of age. Every month, height and weight were measured, and we also have regular samples for enteric infections collected monthly and also during diarrhea episodes. My collaborators at the University of Virginia led the molecular testing for a panel of 29 enteric pathogens. So much of my research has been focused on analysis of those data. But one of the first analyses that I did was really a very descriptive look at antibiotic use in this population. And antibiotic use is strikingly, scarily high in the first couple of years of life in many of these low resource settings. So here on the left, I'm showing incidence of antibiotic use from birth to 2 years of age on the x-axis by each site. This was published in the Bulletin of WHO, and they did not want me to label the lines with countries because that was assuming that the whole country had the same instance as a specific site. So the lines are not labeled particularly interpretably, but these top lines are Pakistan and Bangladesh, so really high incidence in the South Asian sites, upwards of 10 courses of antibiotics a year, just really incredible. And quite a bit of variability, but still, at least 1 to 5 courses of antibiotics a year in the first couple of years of life. Notably in South Asia, access to antibiotics is poorly regulated. You can walk into a pharmacy and pick up antibiotics without prescriptions. Here on the right, I'm showing the cumulative incidence of antibiotic use. Let's see, I can do it on this. Cool. And you can see, by 1 to 6 months of age, about half of children have received their first course of antibiotics. So exposure is very highly common in this population. And at the same time, children are infected with bacterial infections at very high rates. So in the same study, we looked at pathogen prevalence in these asymptomatic stool samples. So these are monthly asymptomatic stools for a subset of the 29 enteric pathogens that we looked at. So this top left here is an aggregate E. coli, one of the E. coli that causes diarrhea. You can focus on just sort of the pink bars, which are the PCR diagnostic detections. And by 6 months of age, about half the stool samples are positive for this pathogen. Campylobacter, around a third of the stool samples are positive. Something like Shigella, which we're particularly worried about, upwards of 20% are positive by the end of the study. So we just have children who don't necessarily present with symptoms, but frequently have these pathogens in their gut. And so this combination of lots of antibiotic use and lots of infections leads to this phenomenon we term bystander exposure. So this is when children are getting antibiotics for some target illness, but it doesn't affect just that target pathogen. It also affects all the pathogens that are in their gut that they're carrying asymptomatically. And so a child could have some sort of respiratory infection, they might get antibiotics, but it's also, providing selection pressure on everything else that they're carrying. And so when you sort of put those two things together, we quantify the incidence of these bystander exposures. So how frequently are these pathogens being exposed to antibiotics in the gut? And that's what this figure is showing. So these are incidence rates on the x-axis. And for the 5 most common pathogens, bacterial pathogens, all of these acronyms are different diarrheagenic E. coli's and Campylobacter species. And you can see that incidence to any antibiotic, it's just hugely high across many of the pathogens, lower incidence for class-specific use. We're most concerned about fluoroquinolone macrolide resistance. But in general, these bystander exposures are extremely common. So in total, about more than 7 exposures per child per year. So where are these exposures coming from? A lot of them are from antibiotic treatment of diarrhea. So in that sort of original descriptive analysis, we looked at sort of rates of treatment for reported diarrhea episodes. That's being shown in this graph. And overall, about half, slightly less than half, 44% of diarrhea episodes were treated with antibiotics in the community. This is not just severe diarrhea, this is sort of all mild episodes that were reported. About half were treated with some variation across sites, but diarrhea is frequently treated. And so when we then classify that with this bystander exposure, we find that diarrhea is a major contributing cause to this bystander exposure. So here I'm showing the incidence of bystander exposure for each of these 5 pathogens. And then the color components of the bars are attributing that exposure to different illnesses. So diarrhea is here in blue at the bottom. Dysentery is bloody diarrhea, which will become important in a minute. And you can see that it accounts for about a 1/5 or so of bystander exposures. Notably, respiratory infections are a huge cause of antibiotic use as well, which I won't focus on because this is a book talk. But still, diarrhea is a major cause of these exposures. And this is completely despite antibiotic treatment guidelines. So the WHO guidelines actually don't recommend antibiotic treatment of diarrhea in almost all cases. These are quotes from the guidelines. It says they should not be used routinely. They increase the cost of treatment. They have adverse reactions, and they can contribute to antibiotic resistance. And they're only reliably helpful for children with bloody diarrhea or dysentery. And the reason they recommend treatment for dysentery is that it's most likely to be diarrhea caused by Shigella, which is a bacteria that can be severe and cause mortality, and it's the most common cause of this bloody diarrhea. So as part of my dissertation, I worked on a similar birth cohort that was only in South India, and we sort of categorized all the antibiotic exposures into whether they were appropriate or inappropriate based on these guidelines. And the vast majority of antibiotic uses were inappropriate. So this is just the total number of antibiotic course clip reported. This study was 3 years, so from birth to 3 years of age. And all of these dark blue antibiotic uses up top here are for non-bloody diarrhea, so what would be technically inappropriate. There were also inappropriate antibiotic uses for upper respiratory infections, that's the gray. And then we really couldn't comment on sort of all the other antibiotic uses. So in summary, for this sort of first section of my talk on burden, in this population, so in children in low resource settings, we have this tricky situation where we're needing to balance access to antibiotics with this excess use of antibiotics. So antibiotics are useful for some causes of diarrhea, like Shigella, but we are very concerned about antibiotic overuse and antibiotic resistance. This high prevalence of bystander exposure in this population, and just the huge burden of antibiotic use in this population. So the work that follows is about trying to critically understand what the impact of this antibiotic use is in early childhood. Okay, so a little bit of work on potential negative consequences of this use. So this was also part of my dissertation work, where I endeavored to understand whether antibiotics could actually cause harm to individual children who were treated. So there's sort of this existential crisis around antibiotic resistance, but that's hard to make that argument to individual people. So this analysis was trying to understand whether antibiotic treatment could actually increase your risk for subsequent illness. And the hypothesis here was that antibiotics disrupt the gastrointestinal microbiota, so the complex community of microorganisms in the gut. And this microbiota could be important for preventing future infections. So if you get antibiotics, you might cause a dysbiosis, and that could actually increase your risk for future infections. And we actually, so this was, again, in a birth cohort that was just in India. It was 500 children. They had a similar study design as the McQuade study. They were followed twice per week, and antibiotic exposures were reported. And so we did indeed find that antibiotic treatment of diarrhea was associated with a shorter time to your subsequent episode. So this is a Kaplan-Meier curve. Essentially, everyone starts at 100%, and then as children get diarrhea, this line shoots downward. So we're comparing the dotted line, kids who got antibiotics for their first episode, compared to kids who didn't get antibiotics for their first episode. And you see that diarrhea happens more quickly, so this line decreases faster for kids who got antibiotics. And we characterize the time difference. So you can see that these lines go almost down to zero. So pretty much everybody gets more diarrhea. It's just so common. But we showed that kids who got antibiotics for their previous episode had their next episode about 8 weeks faster. So they're just having more rapid illness. And this seemed to be particularly an issue for antibiotic use very early in life, so in the first 6 months of life. So we did a second analysis associating any antibiotic use in the first 6 months of life with subsequent diarrheal rates. And we found that there's about a 33% increase in rate of diarrhea for kids who received antibiotics early on. So the mechanism, or the hypothesized mechanism here, is that early on the microbiota is maturing, and sort of early insults with antibiotics could predispose you to future susceptibility. So in summary, we found that some evidence that inappropriate antibiotics can harm children. And the idea is that this potential for increased risk for future diarrhea should be considered at an individual level when making treatment decisions. So when a patient shows up to a clinician, the clinician might think, well, I don't know if this is truly going to benefit from antibiotics or not, but I might as well just give antibiotics just in case, at least it can't hurt. And so providing some evidence that there could be negative consequences to the individual could help promote rational antibiotic use. So my scale here is weighing towards excess from these analyses. There's some full story. So moving on to opportunities for benefit. So what I just showed you was very pathogen agnostic. So it was diarrhea due to any cause, could be bacteria or virus, really didn't look at the etiology of the diarrhea. But diarrhea is a very complex multi-etiologic condition caused by many viruses, bacteria, and protozoa. And there are subsets of diarrhea, specifically those caused by bacteria, that might respond to treatment. And because those treatment guidelines that I mentioned, the WHO guidelines that recommend only treatment for bloody diarrhea, they're so limited. In practice, they're just not followed, right? So we showed, again, this plot here, the prevalence of antibiotic treatment of diarrhea is much higher than would be recommended by the guidelines. And so there's sort of a need to better quantify what sort of subset of diarrhea is truly treatable and can respond to antibiotics. And so we've done sort of a lot of work trying to better quantify the pathogen-specific burden of diarrhea to better inform this question. So again, pulling on data from the IDAS study, this observational birth cohort. One of the very interesting findings from this study was we really uncovered a huge burden of Shigella that was previously recognized. So again, Shigella is a bacterium that responds to antibiotics. It is the one pathogen for which antibiotics are recommended by the WHO. And the WHO recommends that you treat Shigella by focusing on the bloody diarrhea cases. So we found Shigella to be much more common, specifically by using molecular diagnostics, so by using PCR diagnostics. So I'll flip through these two slides. This is a heat map in which each row of the heat map is a child, and each column is a month of life from birth to 2 years. The gray boxes are stools in which a Shigella was not cultured. The orange boxes are stools where Shigella was cultured. So these are detections of Shigella by culture diagnostics. And you can see a smattering of orange, but not a lot. When we use PCR, you see a lot more orange. We also filled in some missing stool samples, but many, many more detections by PCR. Culture is just horribly insensitive in many settings. And so this work really uncovered a much larger instance of Shigella-caused diarrhea than was previously recognized. So here I'm showing the attributable incidence of diarrhea caused by specific pathogens. All the pathogens are listed here for the first year of life and the second year of life. The orange lines are sort of older estimates, and the blue lines are these new estimates from using qPCR. And we can look at Shigella here. It's not so high on the list in the first year of life, but it actually tops the list in the second year of life. And comparing the old method with the new method, we triple the incidence, essentially. Here, there are boxes around Shigella. We also increased attribution to other pathogens as well, but perhaps most striking was this increase in Shigella. And we all sort of know that Shigella causes bloody diarrhea. That's what we're supposed to be treating. But in this study, we found that Shigella was also a primary cause of watery diarrhea, so diarrhea without blood in the stool. So this is showing that association, so the incidence caused by each of these pathogens for watery diarrhea in blue versus bloody diarrhea in orange. So you can see Shigella here tops the list in terms of dysentery, in terms of bloody diarrhea, which is what we would expect. But actually the incidence of watery Shigellosis is much higher. So we're really, by focusing on only treating bloody diarrhea, we're really missing the vast majority of shigellosis cases. Again, just noting that these treatment guidelines are really inadequate. And furthermore, we showed that these bacterial infections are not just associated with diarrhea, but they also have long-term consequences, particularly on growth faltering in children. So I'm showing a lot of figures of data, that's okay. Associated sort of burden of pathogens over the 2 years of life with the child's height at 2 years of age. So this is the difference in height, Z-score, comparing kids with a high and low burden of each of these pathogens. And you see that there are decrements in height for Shigella, one of the diarrheagenic E. coli, and Campylobacter. In contrast, you really don't see that association with some of the viruses. So some of these bacteria that we think might respond to antibiotics, including Shigella, also have these long-term effects on growth. And then to top it all off, antibiotics themselves may be growth promoting sort of independently of treatment of infections. So antibiotics have been shown to be growth promoting in livestock. They are recommended for treatment of acute malnutrition. So a child who comes in with acute malnutrition is given antibiotics without identification of a specific infection. And there have been several studies associating antibiotic use in high-income countries with obesity. So we looked at this question in our study children and found that sort of any antibiotic exposure, especially early in life, so in that first 6 months, was associated with increases in weight. So over all the sites in the malady study, small, but detectable increases in weight among those who received antibiotics. So to summarize these opportunities for treatment benefit, these bacterial infections are just very, very common and could potentially respond to treatment. Specifically, Shigella burden is much higher than we previously recognized, and it often presents as watery diarrhea, not just bloody diarrhea that is recommended for treatment. These bacterial infections are associated with poor long-term outcomes, and sort of independently, antibiotics can be growth promoting. So scales have tipped the other way now. Are we missing opportunities to appropriately treat bacterial infections? Okay, so this last part of my talk will be then talking about sort of potential interventions and the evidence for sort of increasing access to antibiotics, hopefully in the right ways. So I'll first start with the seminal study called Mordor. This was a mass drug administration with azithromycin trial. Yes, the name is Mordor. Everybody laughs at that, and I don't get the reference ever. But so this was not a study that I conducted, but with a seminal study in the field, because it showed that sort of giving everybody in the community azithromycin, so everybody under 5, there was a significant mortality benefit. So not targeted to any infection. This is showing the % lower mortality with azithromycin. So, almost a 15% lower mortality. And it was especially high in Niger, which is the lowest of resources type setting. We were involved in this study in trying to understand sort of what was the mechanism for this effect. The group found that among all the sort of causes of death, there was significant reductions in dysentery. So it wasn't just dysentery, but dysentery was significantly reduced in the communities that got azithromycin. And when we tested stool samples for pathogens, we found that there were significant reductions in Shigella prevalence in the communities that got azithromycin. So there was an overall mortality benefit. There were reductions in a lot of causes of death, but it included diarrhea and dysentery specifically. And we found sort of specific reductions in Shigella, which we have sort of found to be this bad actor. And so this study sort of precipitated a little bit of revolution in how we talk about and think about antibiotics for diarrhea. This was an op-ed by someone in the leadership, or someone in the leadership from the Gates Foundation is quoted. But basically, the argument here is that these bacterial causes of diarrhea are much more common than we thought. The WHO guidelines are really not sufficient, and these are very vulnerable populations, and if we are withholding antibiotics in these vulnerable populations, in which there could be a mortality benefit, that's just unethical. So sort of these scary existential worries about antibiotic use really are pale in comparison to the potential benefit in terms of mortality for the youngest kids in the most vulnerable settings. So so this Dr. Zaidi is a pediatrician, but she also was at a leadership position at the Gates Foundation at the time, and she's quoted saying, when travelers get them, so when travelers get antibiotics, when they get diarrhea, when they go abroad, how can we not give them to children that are too at risk of mortality? So making the equity argument to sort of increase access to antibiotics. So this led to the Antibiotics for Children with Diarrhea trial, or the ADCD trial. This is a randomized control trial of treatment of all watery diarrhea with azithromycin. So contrary to guidelines, but testing, is there a benefit if we just treat everybody? So about 11,000 children were enrolled, half received directly observed therapy with azithromycin, and then were followed for the primary outcome was actually mortality, but also several secondary outcomes, including linear growth. And overall, there was actually not a significant benefit to treating all watery diarrhea. So the primary outcome was mortality at 6 months, and there was a slight reduction that was non-significant. There was a significant increase in length, but this is a very small effect estimate and was sort of downplayed in the interpretation of the study. There were some significant reductions in secondary outcomes, and there's sort of a lot of backstory in the study, but it really was interpreted as sort of a negative overall trial, that antibiotics really were not effective when given to everyone with watery diarrhea. So how was my group involved? We again sort of looked at pathogen-specific causes of diarrhea, so did etiologic testing. And when you subset to the episodes that were actually bacterial, maybe no surprise, but you do see a benefit. So here, these are similar results now stratified by whether it was diarrhea attributed to a bacterial pathogen versus not a bacterial pathogen. And for an outcome of diarrhea on day 3, so essentially did the diarrhea resolve quickly, we see about a 12% reduction in risk of diarrhea at day 3 if you got azithromycin. And we see significant reductions in a combined death or rehospitalization outcome. You see much smaller effects if the diarrhea was not attributed to a bacteria. Interestingly, the growth effect is not dependent on the pathogen, which again may sort of underlie the benefit of antibiotics to growth, sort of agnostic of infections. We also looked in specific causes, and this is specifically for Shigella attributed diarrhea. We see even stronger effects in terms of diarrhea on day 3, so about a 14% reduction, and there really were too few of the other outcomes. But essentially more evidence that antibiotic treatment is effective if we can sort of target it to the bacterial episodes that benefit. So this is sort of, we finally come to sort of where I am now, which is really focusing on better targeting antibiotics to shigellosis and potentially other bacterial diarrhea episodes to really make this balance the right place, right? So we're improving access to the episodes that would benefit while preventing excess, preventing unnecessary antibiotic use for viral protozoal causes of diarrhea. So I'm going to talk very briefly about 3 areas of ongoing work related to these questions. So the first is, how can we better identify children who benefit from antibiotics? And so this is work that's in collaboration with a few PhD students, or one PhD student and a master's student in Epi and Biostats here, and with David Bencaster in Biostats, where we're estimating or trying to characterize this optimal treatment role for diarrhea. So the idea here is that, our assumption is that the bacterial etiology is going to be the main determinant of whether azithromycin works in terms of treating diarrhea. But that's not necessarily the only thing that's important. So there may be other factors that determine treatment benefit. Could be child's age, for example. We might expect younger children to benefit more from antibiotics. We might expect non-nourished children to benefit more from antibiotics. So the goal of this analysis is really to better characterize the subset of episodes that truly benefit. And sort of the secondary aim is, if we can identify that sort of host characteristics like age and malnutrition are strong determinants of treatment benefit, we might be able to leverage that information when we make treatment decisions. So unfortunately, it's really hard at the point of care to know which child has a bacterial diarrhea or a viral diarrhea. We do all these fancy PCR diagnostics, but they're totally for research purposes. They're not available at the point of care. They have to be batched. They take hours of runtime. It's like $100 per sample. It's just totally infeasible at the point of care. And so it's really difficult to know at an individual level what the etiology of diarrhea is. And so if we could sort of characterize the population that benefits from antibiotics from sort of non-pathogen related factors, that would be really fantastic. Optimistic, but something that was worth exploring. So these methods use machine learning on the same trial. So this is the same antibiotics for children with diarrhea trial. So it's using the randomized trial and essentially using machine learning to characterize heterogeneity in the treatment effects. And so what ultimately happens is, for every child in the trial, you estimate sort of their individual level treatment effect. And that's what's plotted on these plots. So each child, we predict what their sort of our best guess is for their treatment effect. So this person down here, this dot has a huge treatment effect. We expect that azithromycin reduces their risk of diarrhea on day 3 by 50%. Conversely, this person up here, we are predicting that azithromycin actually increases their risk of diarrhea on day 3. So we're sort of very, very finely estimating heterogeneity in the treatment effect. And it becomes interesting when we then associate that with different characteristics that essentially we fed the machine learning algorithm to determine the treatment goal. And so of interest, you see that by Shigella quantity, so as Shigella quantity increases, the treatment effect increases. So it becomes more in the negative direction, means more treatment benefit. And this is sort of what you'd expect. You have more Shigella, it's more likely Shigella is causing diarrhea. You might have higher burden bacterial infection. You get a stronger treatment effect. We see that also for STE-TEC, which is another one of these diarrheagenic E. coli, as well as typical EPEC, another diarrheagenic E. coli. And sort of nicely, we see the reverse for the viruses. So you see as rotavirus quantity increases, for example, you actually see the reverse. So you see that azithromycin works less well, which again, we might expect. The more rotavirus that's there, the more likely we think it's actually rotavirus diarrhea. The more higher burden viral infection it is, the less likely antibiotics are expected to work. And so we see that for these 3 viruses here, for example. And so this is sort of along the lines of what we would expect. But more interestingly, we also are showing heterogeneity by some of these host factors. So here, similar plot, but for child age. So you see sort of as we hypothesized that younger children, so the effect goes down with younger children. So there's a larger treatment effect for younger kids. And you also see a strong association with malnutrition. So this is the middle upper arm circumference, which is a measure of malnutrition And so children that have a lower NUAC, that means they're more malnourished, have a larger treatment effect. So we do see that there's heterogeneity, not just by sort of the pathogens, but also by these host characteristics. So this is very preliminary work, but the idea is to sort of fully characterize these treatment roles, fully characterize what the effects would be, and how heterogeneity is determined by these factors. I think long story short, probably pathogens end up being the most important. You really can't rely on some of these host factors. Probably point of care diagnostics are very desperately needed, but this is kind of, it's good to have some real data to support that. Okay, so second ongoing work is to answer this question of how can we effectively target treatment to those children. So as I mentioned, we don't have point of care diagnostics. So are there sort of other ways that we could at the point of care identify children with bacterial diarrhea? So I have a grant from the Gates Foundation to evaluate inflammatory biomarkers that could be measured in stool. So the premise here is that bacterial infections, especially during diarrhea, are very inflammatory, cause a lot of inflammation in the gut. And if we could measure inflammation, we might be able to use that information, sort of incorporate it with other information that we know to predict whether a child has bacterial diarrhea or not. And we think that this is a better or a sort of an additional route than specific point of care diagnostics for specific pathogens, because you could theoretically make these into sort of point of care rapid antigen tests. So like a COVID rapid test, you could have a dipstick that you could put into stool to check for these biomarkers. So theoretically much easier to make point of care diagnostics using the biomarkers than actually looking for the pathogens. So for this project, we are considering 4 different biomarkers: myeloperoxidase, calprotectin, lipocalin, and hemoglobin. Notably, hemoglobin, of course, is essentially just a marker of blood in stool. Sort of observable blood is quite rare, but sort of what they call a cult blood, so detectable hemoglobin in stool, is actually quite a bit more common, and it's predictive of Shigella. So we're trying to evaluate whether these are good predictors of Shigella. So more sort of preliminary data. This is just the quantities of these biomarkers stratified by whether the diarrhea was considered attributable to Shigella or not. So red are the Shigella diarrhea episodes, blue are the non-Shigella episodes. These are the 4 biomarkers: hemoglobin, lipocalin, myeloperoxidase, and calprotectin. And you can see, yes, there's an increase with Shigella, most strikingly so for hemoglobin. Does this really matter? The jury is still out. So doing sort of very simple preliminary model where we incorporate all 4 of these biomarkers, are they sufficiently predictive of Shigella? Sort of. So sensitivity is about 66% at a specificity of 80%, which is not horrible. It's not fantastic. We would like to sort of incorporate other clinical and host characteristics to sort of better improve these prediction scores. So again, preliminary results, but we're still sort of optimistic that these biomarkers could help us improve identifying bacterial diarrhea at the point of care. Okay, and then finally, this third sort of area of ongoing work is trying to understand if and predicting how well we could prevent antibiotic use by sort of other ways. So we know that we need to treat bacterial diarrhea episodes. How can we then prevent treatment for bacterial diarrhea episodes? Seems like a paradox. One nice idea is to use vaccines, right? So vaccines potentially for diarrhea could prevent antibiotic use by preventing the illnesses that prompt treatment. So they could sort of move the needle on antibiotic or AMR in 3 ways. So one would be reducing drug-resistant disease. So I haven't really talked about drug resistance in shigellosis specifically, but it is a large problem and it's growing. So by preventing illness, you may prevent drug resistant episodes. But also you're preventing antibiotic use. So you're preventing some of the selection pressure. It's very hard to sort of change treatment practices when a child shows up to care and is sick. But if you prevent that child from getting sick in the first place, you've prevented the antibiotic use by default. We quantified this bystander exposure, so vaccines could also have an impact on this bystander exposure by preventing antibiotic use. So we have a project funded by the Wellcome Trust that is focused on essentially simulating the potential impact of vaccines for diarrhea on antibiotic use. So here are results specifically focused on a Shigella vaccine. So we, using the MALID data, so this observational cohort data, we simulated on top of that what would we think would happen if we introduced a vaccine and estimated the expected reductions in antibiotic use. So here I'm showing the % reduction in use of specifically fluoroquinolones and macrolides. Those are those two classes of antibiotics that we're most worried about in a variety of outcomes. Each of the bars is a slightly different vaccine scenario. So we assumed sort of multiple doses at different times, all of which are sort of hypothetical options for Shigella vaccines, which are in the pipeline. So if you focus on the sort of Shigella specific outcomes, we would expect to see a fairly significant reduction. So for example, fluoroquinolone and macrolide treatments of severe shigellosis, we would expect almost a 50% reduction. Of all Shigella diarrhea episodes, about a 40% reduction, slightly less than 40% reduction. However, if we're looking at sort of all antibiotic uses beyond Shigella, just a Shigella vaccine would have very modest impact. So, for example, fluoroquinolone and macrolide uses to treat severe diarrhea of any etiology, we'd only prevent 7% of those. Treatments for diarrhea of any etiology, we'd only prevent 8% of those. And then if we look at sort of all uses of fluoroquinolones and macrolides, the Shigella vaccine would only prevent 3% of those. You can sort of look at this analysis, half glass full, half glass empty. Yes, the vaccine would make a significant absolute reduction in antibiotic uses, but again, because these kids get so many antibiotics for so many things, a single vaccine would have relatively limited impact. And we extended this analysis to look at other sort of compare across vaccines for enteric pathogens and also consider combination vaccines. So that's a big priority for sort of global stakeholders is, can we sort of combine some of these vaccines so we don't just have single pathogen vaccines for diarrhea. And so here it's similar outcomes, similar % reductions, but for a variety of pathogens with these beautiful rainbow colors, including some combination vaccines. So this green color here is a norovirus plus a rotavirus vaccine. Blue or teal is adenovirus, norovirus, rotavirus. Pink is the Shigella and the ETEC vaccine. So we sort of tried to expand the gamut of all the different potential vaccines. In terms of single pathogen vaccines, Shigella is generally the most effective when we're thinking about preventing antibiotics for bacterial diarrhea. A rotavirus vaccine, maybe not surprisingly, is the most effective to prevent these unnecessary antibiotic uses for viral episodes. And the combination vaccines, have an additive effect in terms of preventing antibiotic use. So that was a lot of studies and a lot of data. So thank you for bearing with me. In summary, there's really this tension here for antibiotics for kids with diarrhea in which we want to improve access, but also limit excess. And it's a really important population to study because mortality is high and we have really an ethical obligation not to withhold treatment that could benefit children. And at the same time, of course, we need to target therapy to observe the benefit and also prevent these unnecessary consequences like antibiotic resistance. And this last idea is that, preventing the illness entirely by vaccines or other interventions like water, sanitation, hygiene interventions could ultimately be the most effective in preventing antibiotic use. So I will end there and have a lot of people to thank here at Emory, also at the University of Virginia, where I was for many years, as well as sort of the broad range of collaborators at all these international sites and studies where we work, as well as our funders. So thanks so much, and I'm happy to take your questions.
So great, a lot of information, and there's an interesting thread of, trying to detect the pathogen and the immediate outcome, but you also talked about like the biomarkers of detecting things that might be easier to detect at point of care. That's one aspect, but also, just sort of catching it differently without having to drill down to the exact causal pathogen and exact biological outcome to best identify these children. So that combination is interesting in the cross scale kind of aspect. Where can you measure? Where should you measure if you're not trying to figure out the biology of the infection? So that's just an observation, which is interesting. And the question I have is with those growth outcomes, like the adjusted score, with the HAPPEN study, with the reduction in air pollution, those also didn't really show much of an effect. But I wonder, in that amount of time, how strong an effect, what are some other health or treatment things that show a significant effect in 90 days on those kind of stunting measures? Is that something that you see a lot, or it has to be really, really effective, or lots and lots of kids, or?
Yeah, so great question. Lots of descriptive graphs on that.
Yeah.
Not just to talk. There's a lot of, I don't want to say controversy in the field about, so what I showed was purely observational data.
Yeah.
So we see these high burdens of bacterial infections associated with poor growth.
Okay.
But there's this outstanding question: is there residual confounding here? We adjusted for a million things, but is this really causal? So the interventions that I've been mostly associated with are water, sanitation, and hygiene interventions. So there were two huge Gates-funded studies that are thought of as sort of the gold standard studies, WASH Benefits and SHINE, where they poured millions of dollars and did sort of the best possible WASH interventions. Primary outcome was growth, and they all had null results. And so there was a huge question of like, well, what's going on here?
Yeah.
Like, you don't see an effect on growth. Is this not really a causal pathway? Our contribution to those studies was again doing this molecular testing, and we actually showed that the interventions just don't prevent infections. Okay. So there was no difference in infections between the treatment and control arms, and so you wouldn't really expect to see sort of a downstream growth impact. But what that means is like, is this association causal or not is still an outstanding question, because we just don't really have effective interventions. Effective enough intervention. So there's a lot of interest in the vaccine studies. So like a Shigella vaccine, it could be used that. Would you see a growth impact from a Shigella vaccine?
I'm just wondering how far out you have to, time-wise, age of child to have signal instead of noise. Because what happened. So the air pollution indoor the house really went down. This was a randomized trial intervention study. So, similar idea to WASH.
Yeah.
But, they're measuring growth at year 2. And, what we were trying to figure out is why don't we see anything? And, is that we haven't watched them long enough? If we see them in 5 years, and I just didn't know what the WASH experience was.
Yeah, so the WASH experience is different in that we don't see effect on more proximal outcomes like infections. But I think the issue is the same. I mean, growth is so multifactorial.
Yeah.
Bacterial infections make a small impact. The Z-score decrements that I showed in the sort of the most extreme contrast is like 0.2 Z-scores or 0.15 Z-scores. And then, that's for kids that have a lot of Shigella. At the population level, not everybody gets Shigella. So, when you look at this population level, I think it's very hard to see growth and difference.
No, that's interesting.
Yeah, I'm pretty pessimistic about the potential for vaccine trials to show an effect on growth, unfortunately. But it's very interesting because that's, one of the huge sort of arguments for a Shigella vaccine is that it would prevent stunting.
Right.
Which is, I think, setting ourselves up for disappointment.
Yeah, and just like the last piece, it's sort of that kind of outcome, the primary outcomes of interest, if those are hard to see an effect, but the malnutrition ones are something more acute, might, yeah, I don't know.
Yeah, so people have also looked at sort of short-term faltering
Yeah,
after a
okay.
growth episode. And you do see, especially, it's interesting, untreated shigellosis. So if you treat Shigella with antibiotics, you actually prevent the growth faltering.
Oh,
But untreated shigellosis does cause growth faltering in the 3 months following. I think it's just a question of like, in a vaccine trial, how do you measure that short-term effect if you've prevented diarrhea? And so it's just, again, hard to sort of quantify.
thanks.
I have a slightly more ecological question, and it's really thinking about the Shigella. So when the Shigella causes this diarrhea, so presumably it's circulating in the population, it gets into the gut of children, and it presumably if it reaches some density, it starts causing these problems. So instead of thinking about a vaccine to prevent it from coming in, is there any research going into thinking about, say, probiotics and changing the microbiome so that these pathogens cannot establish?
Yes. There's a lot of interest and excitement about probiotics. I haven't seen any compelling data to suggest that they work, unfortunately. Yeah.
It's a shame.
I don't, yeah, unfortunately. But I think that interest in, I didn't talk a lot about sort of why we think malnutrition is associated with these infections and these poor outcomes. It all has to do with sort of dysbiosis of the gut, which involves sort of microbiota issues. And so I think there's the potential there to sort of improve gut health generally. We think that's on the causal pathway specifically for these growth outcomes. But just haven't seen, again, like from the intervention studies, really benefit from probiotics. Yeah.
Kind of along those lines of sort of gut microbiota, are there a lot of synergies or antagonisms amongst the pathogens themselves and some of these asymptomatic folks who have multiple pathogens? Kind of at a larger scale, do you see some coexisting more frequently or not?
You get the prize because at every talk ever, someone has to ask about co-infections. So thank you. It's very hard statistically to show synergy, which maybe you know most acutely than anybody else. So so the McQuade study, it's a huge study, very well funded, but it still was only like 200 kids per site. And so we actually don't have that much power to really look at synergies between pathogens. And so you don't really see significant evidence of like 2 pathogens being worse than sort of the additive effect of both of them alone. We frequently do see sort of multiple pathogens that are present during diarrhea at an attributable level. So we think there may be multiple causes of diarrhea happening at the same time. But it's really hard to tease out, are they actually synergistic or are they just co-seasonal because seasonality is very similar, transmission pathways are very similar, so are they just being adjusted at the same time? So if you have good suggestions for how to sort of tease that out, we'd be all ears, but it's really hard to sort of figure out if there's true biological synergy versus just sort of co-temporal overlap with these things. The number of co-infections is huge. I mean, if you just, the prevalences of those pathogens were so high that on average you get 2-3 pathogens every time you look.
The border study was super interesting. When you're looking at the impacts on overall mortality, do you also see decreases in people who are not being treated with antibiotics, like the older people, or is it really the benefit focused on the treatment population?
Good question. So that, like, are there indirect effects?
Yeah.
In terms of mortality, I don't think that was observed. Again, I had a relatively small role in Mordor, so don't know the whole literature, so don't quote me entirely. The one area of interest for looking sort of outside the treated age group was on resistance. So that was a big question, was like, if we treat the youngest kids, are we gonna see resistance in older children? Are we gonna see sort of changes in pathogen densities in older children? So to that question, we have done some work. So we've tested actually respiratory swabs on older children and looked to see if there are reductions in any respiratory pathogens. There weren't, so we didn't see sort of indirect effects on respiratory pathogen carried in older kids. But yeah, that's the one area sort of in indirect effects that I can come up with for that study.
Sorry. So in terms of I don't know much about Shigella, but are these specific, do you know anything about the kinds of strains? Are they circulating just in humans, or is there livestock involved in this as well? So again, thinking about where do they come from, are there other ways to stop them from coming in?
Yeah, great question. Very interested in this. We have an ongoing transmission study in Tanzania and Bangladesh where we're trying to sort of nail down transmission pathways better, specifically for Shigella and Campylobacter. Shigella is thought to be actually mostly person-to-person transmitted. So there aren't reservoir, sort of animal reservoir hosts. It is the common cause of like daycare outbreaks in high-income settings. So we see a lot of evidence of person-to-person transmission. But actually, the reason why we're doing this transmission study is that in these high burden settings, there's probably a larger contribution from environmental transmission than is recognized. And so we're really trying to understand sort of what specific pathways might be important. The inoculum to cause disease for Shigella is very, very small. You only need to ingest very few bacterium. So that leads to sort of very unique transmission pathways. So there's this hypothesis that flies are a major transmission route. So flies land on feces, become contaminated with Shigella, and then they sit on milk, which is, especially in our Tanzania site, sits on the stove all day. It gets boiled and then it sits. The flies sit on the milk, and the children ingest the milk. So we are collecting flies and testing them. And yeah,
That's ecology.
yeah, very interested to see if that is, as well as sort of water and soil and their food and other transmission.
Well, thanks again. Thanks for that.